And I couldn't have timed the order of the presentations better, because mine kind of dovetails very nicely into from Lisa and Tracy's presentation. So it's a pleasure to speak to you today about our PQI project, which focused on improving pain and withdrawal management for people with opiate use disorder at Kelowna General Hospital. So my dyad partner is Amanda Cadulas, who unfortunately isn't able to be here today. And our PQIC was Michelle Kramer, and I wanted to thank Lindsay Boulay for supporting with data and analytics for the project. So over the past 8 years, British Columbia has faced a public health emergency with over 14,000 deaths attributed to toxic drugs. This makes drug toxicity the leading cause of death among individuals aged 10 to 59 in our province. And since the public health emergency was first declared, there has been an increased focus on improving educational efforts for opiate use disorder management. However, this has generally focused largely on community settings and to a lesser extent on emergency room settings such as programs in IH, such as the Suboxone to Go program. So we often treat substance use disorders in acute care like a big elephant in the room. And this is historically, as Lisa and Tracy had mentioned, it's been really under-taught in both medical school, residency training, as well as in nursing school. So we know that hospitalized patients with opiate use disorder have high rates of patient-initiated discharge or patients leaving AMA, and then subsequent readmission as well as post-discharge mortality, which this has largely been reported in the literature to be secondary to stigma, as well as inadequate pain and withdrawal management in hospital. Additionally, we know that when patients' pain or withdrawal needs are unmet, they are more likely to self-manage. Nursing staff often express uncertainty regarding optimal opiate use disorder management, including concerns around administering higher dose opiate PRN medications. So when we first set out on this project last year, we knew anecdotally that substance use occurring in hospital was a big concern. I knew this because I was involved in a number of PSLS reviews. I work as an addiction doc at Kelowna General, so I would be called if there was a concern that a patient was using in hospital. But this has really exploded in the media in the last couple of months. So these are all headlines related to substance use in acute care occurring in BC from just the last 2 months, so April and May of 2024. So our primary aim was to improve pain and withdrawal management for patients with opiate use disorder at KGH. And we had 2 target units, so one of the psychiatry units and then one of the medical units. And we looked at a chart audit tool that we developed, and we hope to improve scores by 50% from our baseline data to April of 2024. And then our additional aims were to increase nursing confidence in caring for patients with opiate use disorder, decreasing patient-initiated discharges, so patients leaving AMA, as well as decreasing PSLS events. So in total, we did 4 nursing education sessions on 2 different units. So 1 medical unit and 1 psychiatry unit. In the psychiatry unit, I was somewhat surprised by this, but they actually requested a longer format, so like a 1-hour session. And then the medical unit requested a more kind of typical in-service education session, so kind of 10 to 15 minutes. So the deliverables that were created throughout this project included a PowerPoint presentation that was kind of 45 to 50 minutes in duration. And then we developed a number of handouts for nursing staff. So we developed 4 handouts in total. And they really went through kind of multiple iterations. So my first version I thought was okay, but it was more kind of akin to how I would study during medical school. And I got feedback that that was not a very good handout. And so we stylized them and made them kind of much, I think much flashier. So we got content and design style kind of feedback from multiple different stakeholders, including nurses, as well as the BCCSU, which is a BC Centre on Substance Use, a provincial organization. And we incorporated that into our finalized versions, and this QR code links to all the finalized handouts. So we developed a 8-question chart audit tool where I assessed management of pain and withdrawal for patients with opiate use disorder that were admitted to the target units. And essentially a higher score was a better score. So overall, there was a trend towards improvement in the scores and less variability over time, but this was not found to be statistically significant. Over the course of the project, I kind of recognized that there was a lot of limitations to this tool that we developed. So if there was one very stable or one very unstable patient that was admitted to a ward, this could potentially really skew our results. We also didn't have a lot of control as to where patients in the hospital were admitted. And so sometimes we'd have many patients admitted to our medical unit, and sometimes we would have like a patient with opiate use disorder admitted to that ward for several weeks at a time. So some of the key learnings from this project were that I likely overestimated my own capacity to do nursing education on a kind of ongoing and consistent basis. So I found that really tough to balance with clinical duties. I initially thought I'd be able to do like maybe 12 education sessions, and that's just like not feasible. I also found that with education in general, it's not kind of one and done. Key messages really need to be repeated, and really the education needs to be repeated on the same ward, even just to capture all staff, like especially the medical units. Sometimes that I'd be able to get like 4 or 5 nurses, and so it's tough with the nursing schedule to just get all the staff to attend. Another key lesson was that really culture change takes time, and it's really hard to measure. So I had initially kind of sought out to use this metric called the Medical Condition Regard Scale, which is a validated tool to measure a healthcare provider's willingness to care for a patient with a particular medical condition. So I wanted to use that as kind of a way of assessing stigma in hospital, and do it kind of before and after the education. Unfortunately, we ran into a number of roadblocks in using this tool, and as a result of a moratorium on staff surveys, we weren't really able to use this as a metric. But I think if the project were to spread further, I think this could be a really valuable measure as a way of measuring stigma and kind of culture change and approach to patients with substance use disorders over time. So what's next? I had mentioned earlier that there's kind of a lot of momentum or disruption, or however you want to describe it, in terms of improving and advancing education around substance use disorders in acute care. And so as of fairly recently, this is now kind of ministry mandated work, and is a really kind of within the organization as well as provincially, there's a lot happening, looking at ways to improve management of substance use disorders. So I'm now part of a provincial working group, working with the BCCSU, tasked with developing physician and nursing education on this topic. And I've shared some of the deliverables that were developed for this project with that team for consideration. And then this project really would not have been possible without all of these people listed on this slide. So I just want to sincerely thank them for supporting this project. Happy to answer any questions.